All right, good afternoon, everyone. Thank you for joining us this afternoon. We apologize that we're a few minutes late in getting going with this breakout session. We've had a little bit of technical difficulties and are trying to pivot a little bit, but excited for our next presenter. This session is orthopedic management of mucopolysaccharidosis, and really excited to have one of our experts, leading experts in the field, a doctor here who's been very, very active with the MPS Society and is always providing a wealth of information. So I just want to take a minute and introduce Dr. Klane White. Dr. White is a pediatric orthopedic surgeon and director of skeletal health and dysplasia program at Seattle Children's. He's a professor of orthopedic surgery at the University of Washington and a diplomat of the American Board of Orthopedic Surgery. Dr. White is an internationally recognized expert and advocate in the care of mucopolysaccharidosis and skeletal dysplasia. He serves on the medical advisory board of the Little People of America and is a founding member of the Skeletal Dysplasia Management Consortium. And he served 3 terms on the National MPS Society Board of Directors, and he continues to chair the Technical Grant Review Committee and is on our Scientific Advisory Board. He's a wealth of information, and something that's very unique and special to us about Dr. White, not only does he specialize in this with MPS patients, but he also is the parent of an MPS I child as well. So brings both perspectives, which is just really special to all of us. So with that, I'm gonna turn it over to Klane. Unfortunately, we're having some video issues with Klane, but you will be able to hear him and see his slides, and he will be available for Q&A as well after the next 2 presenters. We have time for Q&A. And so with that, I'm going to turn it over to Dr. White.
Thank you, Lisa. It's always a pleasure to be part of the National MPS Society meeting, and it's a shame we have to do this virtually. Lisa and I were just sort of commiserating about the fact that we don't get to see each other this year in person, but certainly by next year, we hope that that will be the case. So again, I will be talking today about orthopedic management of MPS. And as Lisa mentioned, I hopefully bring a unique perspective to this. Not only am I an orthopedic surgeon who takes care of children with MPS, but I'm a parent of a young girl, Susanna White, my daughter. She died, unfortunately, in 2008 due to complications of her disease, but as you can see, was a bundle of joy, and we miss her immensely. But I think hopefully it brings me a slightly different viewpoint when talking to families, and when hopefully make you feel more comfortable talking to me. So with that, we'll move on with more of the educational component of this. I'm just going to start a little bit with orthopedics, what I like to call orthopedics 101. So pediatric orthopedics is a little bit of a redundant term because orthopedics actually means straight child. And it's been subsequently sort of abducted by our adult colleagues. But what we do is we take care of children, we take care of their musculoskeletal issues. So we care for them in the treatment and prevention of musculoskeletal disorders. So pediatric orthopedic surgery is not, we are not just surgeons, we are the full complement of both operative and non-operative care in musculoskeletal concerns. But for us, we have specific interest in children, and so a pediatric orthopedic surgeon takes care of those conditions that are specific to childhood. And so that really means that genetic disorders have historically fallen under that umbrella. And with that said, I consult often with adult patients with rare genetic disorders, skeletal dysplasias, and MPS as well. And so our goal is to maximize function and abilities with regard to extremity deformity, spinal deformity, and joint disease. So when we speak about musculoskeletal disease in MPS, there's a term we refer to which is called dysostosis multiplex, which is a very specific term to MPS. And it's really just Greek for multiple bad bones. It refers to the diffuse skeletal disease that we see in MPS. Much of the research that we have suggests that this is related to inflammation as a result of GAG accumulation or MPS accumulation. And what we see is a progressive deformities, or we see multiple progressive deformities in childhood, which are generally not reversible unless we do surgery. And then in later childhood, early adolescence, and adulthood, we see joint degeneration. And I'll explain what that means. And there can always be some residual deformities from childhood that may not have been addressed. So when we discuss deformity, we look at it in multiple planes. So the human being is a three-dimensional being. And so when we look from the front, we call that the coronal plane. And we're looking at the lower extremities. We talk about varus and valgus. So varus is when the angular deformity angles away from the midline. Valgus is when the deformity angles towards the midline. So you can see this in the lower extremity. So bow legs are varus or genu varum, knock knees or genu valgum. We see in the elbows, we see cubitus valgus, that's angling towards the midline, and cubitus varus is angling away, and that's referring to the elbow. We also, when we look at the spine, this is what we call scoliosis. So we see an angular deformity in the frontal or coronal plane. The other two planes we look at are rotational deformity. So rotational deformity, you can see in this cartoon on the left, is when we're evaluating femoral rotation. So how much do the legs rotate in or out? You can also look at the upper extremities and how much, if you put your elbows to your side, how much do your palms turn up and how much do they turn down? That's a rotational difference. And then if you look from the side, we call that in the medical term sagittal plane. So your knees bend forward or they bend backwards. And if we look at your spine, do you have a forward bend in your spine, which we call kyphosis, or do you have a sway back, which we call lordosis? So these are the terms you'll hear throughout this talk. Joint disease is a little bit different than deformity. So this is a nice cartoon which shows what a normal joint should look like, with nice glistening cartilage at the end of the joint, a very smooth capsule to the joint. We call that the synovium. That's what holds the joint fluid around the joint and keeps the joint well lubricated. And then if you look at that arthrosis picture, the cartilage starts to wear down. You see a thickening and inflammation of the joint capsule. We call that synovitis. And this is a very common manifestation of MPS in adolescents and adults. When we're speaking about Morquio syndrome specifically, we can have real significant joint laxity. And so that picture on the right is a patient with Morquio syndrome who can do sort of what most would consider party tricks with their joints because they have extra laxity in their ligaments. Now, other MPS conditions have what we call contractures, where the joints are actually stiff. And that's the vast majority of other MPS conditions. Stiffness is much more common than laxity. When you see an orthopedic surgeon, or any doctor for that matter, I think I would encourage you to ask not what they can do to your child, but what they can do for your child, or if you happen to be the patient yourself, what they can do for you, or as opposed to you. And so when we address patients, we want to know, can we make you better? Not can we make you different. So we are not treating an X-ray abnormality. We want to make sure that you are a much more functional human being with a better quality of life. So the questions you want to ask, if you do an intervention, whether it's surgery, medicine, or whatever, will it improve function? Will it decrease pain? Will it increase quality of life? These are very important questions to ask your orthopedic surgeon or any physician that you engage with. And you always have to ask, what are the alternatives to surgery? Well, oftentimes weight loss or good maintenance of health can reduce joint pain and stiffness and improve quality of life. Assistive devices such as canes, walkers, or as pictured here, wheelchairs, can improve independence and quality of life. Braces, shoe inserts, and then pain-relieving medications, whether those are oral medications or injectables, are all alternatives to surgery. When do we decide to operate? Well, we decide to operate when the alternative to not operate is not a good option. So an operation will be a better outcome than doing nothing, or the non-operative measures I just mentioned have not worked to the satisfaction of the person in question. So certain aspects we look at are pain and deformity that may limit everyday activities, certainly pain at rest, whether it's day or night. Sometimes if there's stiffness that we can improve with surgery, but it has to be substantially improved. And again, this has to actually improve the quality of life and function of the individual. And sometimes we just know that if you don't intervene, that things are just going to get worse. And so it's better to intervene now than to wait. So this is a really complex slide, so I don't expect anyone to memorize this, but this shows our most common forms of MPS. And then going down the left column and across the top row, you can see that there are many orthopedic considerations that we worry about, and those can involve the spine, the hips, the lower extremities, and in the upper extremities, most commonly, we talk about carpal tunnel syndrome. So I'm going to review each one of these aspects, and I'm going to start with the neck. So cervical stenosis, what does that mean? Cervical stenosis means narrowing of the spinal canal, and this happens to be in the neck region specifically, is where we have the biggest problems. So you can have narrowing, but you can also have what we can consider instability, where the vertebral bodies tend to move on each other more than they should, and I'll show you an X-ray image of this to illustrate. But this is all part of the biology of MPS, where the bones are underdeveloped. So you have underdeveloped odontoid process, which is the bone that sits in front of the spine, just below the skull. The ring around the back is underdeveloped and small, so the canal for the upper cervical spine is smaller. And then you can have, on top of that, you can have thickening of the dura. This is the lining to the spinal cord. And so that combination of small bones and thickening of the dura results in compression of the spinal cord. And so spinal cord compression really ultimately is what causes dysfunction and disability. And that's what we're worried about. Now, C1 and C2 instability is common in Morquio syndrome, less common in other MPS disorders. But when those vertebral bodies move inappropriately or too much inappropriately, then that narrows the canal even more and can cause injury to the spinal cord. So this is a CT scan on the left and an MRI on the right. And if you look at the top of the spine, there's arrows on the CT scan on the left that show that you can see the bone is sitting forward there. That's C1. And then the bone below it is the odontoid process, which is C2. And you can see that there's because that bone sits forward, there's a narrowing of the spine there. And if you look at the MRI on the right, you can it might be a little hard. These slides might appear a little small, but there's a little blush in the spinal cord there. So not only is that spinal canal narrow, there's not much white space around the spinal cord, but there's a blush in the spinal cord where that spinal cord has been injured. And so that's one reason, that MRI change that we looked for that might prompt an intervention. So maybe many of you have seen slides of cells with MPS, and we see this accumulation of glycosaminoglycans or mucopolysaccharides. Well, again, the dura around the spinal canal and spinal cord is no different. It has these same sort of foamy cells. And so this is what results in that dural thickening. So in some disorders like Hurler-Scheie and Scheie, or an MPS VI, this thickening is so substantial that even if you have normal bony development, you can have narrowing of the spinal canal. And so here's an MRI of a 35-year-old woman or so who was a school teacher, but had this significant narrowing and started to develop signs of spinal cord compression. And so it's not always just at the very top of the spine, and it's not always because of instability. And I think that's a common misconception. So what are the symptoms of spinal cord compression or cervical stenosis? Medically, we refer this to as myelopathy. How would you witness this as a patient or a family member of a patient? Well, the person affected becomes weaker in their arms and their legs. They become clumsier. They have an unsteady gait, and they may start developing urinary retention. and in advanced stages, actually incontinence of urine and bowel control. With instability, sometimes because the body is the muscles are working harder to hold the bones in place, patients will experience neck pain or headaches. So sometimes we need to operate for this. And when do we operate? Well, if we can detect changes in your neurologic status by exam, or if there's obvious instability on the x-rays, so that C1, C2 vertebral bodies are moving way too much, and we have established norms for that. Or, as I showed in that MRI, if you see evidence of cord injury with that blush in the spinal cord, then those are definite reasons to move forward with surgery. And usually that surgery is going to be a decompression of the spinal cord plus or minus a fusion. And in our institution, we are very proactive about doing fusions when possible, because it seems that decompression alone has a higher incidence of recurrent disease. So that's something to consider. Moving down the spine, thoracolumbar kyphosis, which is also known as a Gibbus deformity, is the most common spinal manifestation of MPS. Over 90% of children with Hurler syndrome present with some form of this deformity. It's usually progressive, but not always. And so it's important to understand the natural history of this problem so to know whether you need to intervene or not. Again, it's the most common spinal deformity in MPS. Treatment can, in young children, include bracing to try and prevent or at least slow progression, and may delay the need for surgery, because we'd like to let the spine grow as much as possible, as long as possible. And again, bigger deformities tend to progress more than smaller deformities, and that number has been set at about 45 degrees. This is an example of a child with Hurler syndrome, and you can see that there's a subtle forward bend in the spine. And this is what we do surgically. We do surgery. You can fuse across the vertebral bodies in the front with instrumentation.
Thank you.
We seem to have extra people on our line. So sorry about that. And so then we see instrumentation in the back. And so this is a standard procedure, and you can do this surgery either through 2 incisions, or many surgeons will now do this surgery through 1 incision, all from the back. But you need to make sure you address the entire deformity. And here's the instrumentation with the posterior fusion. And oftentimes we'll brace these patients afterwards. The younger the patients they are, the smaller their bones, the more likely that these patients will need to be braced or tasted after surgery. This is just another example. It's a little hard to see in the x-ray on the left here, and I'm sorry I don't have access to a pointer, but you can see on the MRI in the middle the significant kyphosis or gibbus deformity, and then on the right we see the surgery after fusion with the anterior fusion, which is harder to see in this case, but there definitely was an anterior fusion, and then posterior instrumentation and fusion. Scoliosis, again, is the deformity where we see a side bend in the spine. But more than that, it's also a rotational deformity of the spine. So if you look at this picture, the ribs on the right side are more prominent than the left. And because of this, the lungs can be compromised. And so scoliosis is not, we're not as concerned as with neurologic injury as we are with pulmonary compromise over the long run. Fortunately, scoliosis is less common in MPS than kyphosis. This is a patient with Morquio syndrome who had a scoliosis that was getting worse. He also, it's hard to see, but a little bit of a kyphosis at the apex there. And so he underwent a pretty typical surgery for scoliosis with a long instrumented fusion, but this was an all posterior procedure. Moving down to the hips, I'm sharing an x-ray on the left side, which is what normal hips should look like. You see a nice round head to the femur that sits in a nice round socket, which we call the acetabulum. Okay, and then if you look at the MPS I patient on the right, the femoral heads are not very round. They're kind of flattened. The socket is very shallow, and the hips are subluxating out. And so here's an X-ray. This is that same X-ray. And so what we look for is what we call a break and Shenton's line. And so the dotted line is where the femur should sit, and the straight or the solid line is where the femur sits now. And what that basically is demonstrating is that femur is sliding up and out. We also have, again, a very shallow socket, so next one is shallow socket, but this is what the shape of the femur is abnormal, which contributes to this deformity. And then we have a shallow socket, as demonstrated by an increased acetabular slope. And all of these deformities combined result in that subluxation, lateralization of the femur. So this is hip dysplasia. It can look different in different patients. This is a hip X-ray from a patient with Morquio syndrome, and here you can see there's a significant erosion of the femoral head. So look how flat and eroded they are. They're very irregular looking. The hip on your right, which is the patient's left, is starting to slide out of socket as well. So we call that progressive subluxation. And these hips become extremely painful. So the question is, when do we intervene for hip dysplasia? And so we've tried to pin this down a little bit. And again, this might be a little small to read, but early corrective surgery should be considered for MPS I and probably MPS IV, but we don't have really defining research on this. But the indications at this point are progression of the disease, as I've shown with subluxation of the hip, presence of pain or disability, or as we know for MPS I and MPS IV, so Hurler syndrome and Morquio syndrome, the hips do tend to get worse with time, and that is a known natural history. So how do we treat them? This is a surgery that I perform, and other centers perform similar surgeries, where we cut the bone above the socket, put bone graft in there, get those hips nicely centered in the socket by cutting the femur and turning it into the right position. So this is what we call pelvic and femoral osteotomy, and what we're doing is trying to get the hips in best alignment. So how well does this surgery work in the long run? In the Minnesota experience, of 102 hips that were operated on or that were looked at, of which half had surgery and half did not, we had basically an equal number of patients who developed arthritis who had surgery and those who didn't. So it didn't necessarily prevent arthritis at a higher rate if the kids had surgery. And if we look at the Irish experience, they had similar findings where hips that were attended to at a young age, you can see many of them developed advanced degenerative hip disease on one or both sides. Now, I'll say there are other reasons to consider hip surgery in terms of medium-term expectations, and also reorientation of the bone stock. So if the patients do need a hip replacement at some point later, which I won't talk about today, then the bones are in slightly better condition. Knock knees present early. These definitely affect the mobility. That's why they're called knock knees, because the knees knock into each other. We can do small surgeries for this. We used to have to do what we call osteotomies, where we cut the bones and realign them. But MPS children respond very nicely to guided growth. You may have heard the term 8 plates, but there are many other brand names that can be used in this regard. This is what we can expect, where the yellow line should go through the center of the knee. The knock knees on the left X-ray are actually are kind of overcorrected on the right side, where the knees are now a little bit bow-legged. So we do that intentionally because when you take those plates out, there tends to be a bit of a rebound effect. This is a slide from a publication from DuPont, and you can see the multiple different mechanisms used to try and straighten these knees and treat these hips. You can see external fixators, frames placed on after osteotomies. You can see hip X-rays where they did the surgery similar to what I showed you earlier. And then it's a little hard to see, but on the bottom aspect, you see those 8 plates placed, and that would be an E and F. And then the knees were made straight or, again, slightly bow-legged. We know that this growth modulation or guided growth works. It shows nice correction in multiple studies, and it improves mobility in terms of 6-minute walk test and so forth. Moving to the last aspect of musculoskeletal that we'll talk about, the hands. Carpal tunnel syndrome is common in all forms of MPS. It's a little less common in Morquio syndrome, but I have seen it. Trigger digits are very common in Hurler syndrome after transplant. And so what happens is you get thickening of the lining to the tendons that surround the nerve that innervates sensation of the hand. This can present with motor weakness or numbness in the hands. And I get in trouble for saying this, but I still have not seen a patient who had pain with neurologic deficits in these symptoms, but I know that other families have had experience with that, and it probably has much to do with what point was the intervention warranted. So very close monitoring is required here. This is just what we look at for carpal tunnel syndrome. There's that median nerve that gets pressed under the transverse carpal ligament that needs to be released and then cleared. What will you see in your child or in yourself is clumsiness, changes in sensation, sometimes gnawing of the hand, the muscles start wasting away, decreased sweat. So I recommend, at least in children who can't communicate well with us, nerve conduction studies at least once every year or two. Generally, these don't need needles, but oftentimes we'll still do EMGs, which do require needles. And so if they do need needles, then we'll often do this under anesthesia. Having a good hand therapist around to monitor your outcome, your child's outcome is important. And then these are some pictures of trigger digit releases and carpal tunnel release in a patient with Hurler syndrome. So how does medical management affect the musculoskeletal system? Well, we know that stem cell transplant reduces some of the orthopedic burden, but for the most part, there is still significant skeletal disease in MPS I after stem cell transplant. And to be clear at this point, I'm only addressing MPS I because that, in my mind, is the only MPS that I think is really appropriate for a stem cell transplant. But what you see is a patient shown on the left here, this classic photo, turns into these patients, like these little boys who are actually active out on the playground and having a very functional childhood. I referred to this earlier. We see worsening of hip dysplasia in MPS I over time, and what you can see is these box plots will get higher and higher relative to what's normal, and so that's worsening hip disease. We see that spinal cord compression is more common in patients who have less enzyme or who are transplanted at a later age. We also see more carpal tunnel syndrome in patients who have less enzyme and patients who are transplanted at a later age. So early transplant with good enzyme level does seem to have some benefit. Enzyme replacement therapy does not seem to show any appreciable benefit to bone. It does reduce joint stiffness and improve 6-minute walk tests and maybe accelerates growth. There is some thought that if you start as an infant, that early ERT may benefit some of the bones. I will say if you look at the x-rays, they don't look too different, but there seems to be less deformity. And if you look at the facial bones features, then there's certainly some improvements. And this is, again, a brother and a sister started in a 10-year follow-up. If you look at their bones, her bones don't look that much better than his, but if you look at just her facial features, I think it's pretty easy to appreciate that she has much less coarseness in general. Gene therapy, as was spoken about earlier by Dr. Ellenwood, has not been shown to be effective yet in bones and joints, at least in animal models. While the animals all did well in terms of survival, the x-rays and the histology really did not improve. So as I said at the beginning, the question is, does orthopedic surgery improve the quality of life and the function of MPS? Because this is really what we want to go. So surgery may improve quality of life, particularly with regard to genu valgum, but the research up to now is not great, and we're really still kind of flying a bit half blind. A couple comments about airway and anesthetic management. Make sure if you or your loved one is going to have surgery, they have a thorough preoperative evaluation, including pulmonary, cardiac, and ENT evaluations, that the anesthesiologist is skilled at difficult airways, and for any procedure that's going to last more than an hour, that they are monitoring yours or your child's spinal cord, because we have had multiple patients wake up paralyzed. This is a patient who had hip surgery of mine. This was now over 10 years ago, but we learned the hard way that you can do a beautiful hip surgery and then it's completely worthless because that patient will never walk again. So in summary, MPS results in skeletal dysplasia with result in deformity and joint disease. Surgery has a major role, but there are other options. And I think we're still hopeful that medical therapies in the future will be able to target bones in a more effective manner. So here's my shout out to Lisa from last year, Team Todd. And with that, I will pass on the microphone. Thank you.
Thank you so much, Dr. White. Your presentation is always very informative. We have a lot of questions in the Q&A. So what I'd ask is if Dr. White will take a look at those, we're going to move on to our next presentation by Dr. Wood. And then again, we'll have time at the end of Dr. Wood's presentation to address both questions from Dr. White and Dr. Wood's presentation. So Dr. Wood is here today to talk about airway problems with patients with mucopolysaccharidosis. And I'm just going to take a minute to introduce Dr. Wood before his presentation. Dr. Wood received a PhD in 1968. He's been practicing for quite a long time, and we're lucky to have him in our community. He received his PhD and MD from Vanderbilt University and then did a residency at Duke University. Following 2 years at NIH, he completed a fellowship in pediatric pulmonology at the Children's Hospital in Cleveland, Ohio, and remained at the facility there until 1983. He then went to UNC at Chapel Hill, where he founded the Division of Pulmonary Medicine at the Department of Pediatrics. And while at NIH, he developed skills in flexible bronchoscopy and utilized a flexible bronchoscope for research. Upon his request, the Olympus Corporation created a flexible bronchoscope small enough to be used in children. And Dr. Wood was the first physician to use this instrument. He has since trained more than 2,300 physicians from more than 85 countries in the use of this flexible bronchoscopes in children and principles and practice of pediatric bronchology. And you'll hear today how important that is. It's really quite spectacular. He's had a long particular interest in specific airway issues related to MPS disorders and is widely recognized as a pulmonologist with the most such experience. In 1999, he moved to Cincinnati Children's, where he helped found the Aerodigestive Program, an innovative multidisciplinary program for the diagnosis and management of children with complex airway and feeding problems. And while at UNC, Dr. Wood was a close colleague of another expert who we've heard from today, and we all know and love, Dr. Joe Munzer. And he's followed many patients collaboratively, even after moving to Cincinnati. And since July 2020, Dr. Wood is now retired from clinical practice. Congratulations, Dr. Wood. But he will become Emeritus Professor of Pediatrics at the Cincinnati Children's Hospital, remaining active in teaching and writing. So with that, we'll turn it over to Dr. Wood. Thank you.
Good afternoon. I'm Dr. Robert Wood from Cincinnati Children's Hospital. I've been dealing with airway problems in patients with mucopolysaccharidoses for more than 45 years now. This afternoon, I would like to share with you some of the things that I have learned. Let's begin by talking about the ABCs of human survival. A stands for airway. If you don't have an airway, you cannot breathe. B stands for breathing. If you cannot breathe, nothing else matters. C stands for all that other stuff, your brain, your heart, your muscles, etc. The lungs are the most important organ in the body. Everything depends on the delivery of oxygen to the body's tissues. Nothing works without oxygen, at least not for more than 3 to 5 minutes. Oxygen comes from the air we breathe. Air must get to the lungs. The pathway to the lungs is the airway, which begins at the nose. Let's now review the human airways. The nose is a very complex structure that warms, filters, and humidifies the air that we breathe. It does more than smell mama's cooking. The larynx is the gateway to the lungs. Closure of the vocal cords protects the lungs as we swallow. The vocal cords also form the basis of our voice. We like to talk about the tracheobronchial tree. The trachea, the bronchi, and the alveoli of the lungs are very much like the trunk, branches, and leaves of a tree. Let's talk about the structure of the human airways. The trachea, or the windpipe, is very much like the trunk of a tree. The bronchi are the delivery system for air. The bronchi branch very much like the branches of a tree. There are 22 to 25 generations of branches, meaning there are millions of the smallest bronchi, which lead to the alveoli. These are the air sacs where oxygen and carbon dioxide are exchanged with the blood. The alveoli are analogous to the leaves of a tree. Bronchoscopy is the examination of the airways. A flexible instrument, a flexible bronchoscope, is passed through the nose, through the back of the throat, between the vocal cords, and into the lungs. Here's a 2-minute tour through the normal human airways. Here's the nostril. That's a booger. That's an occupational hazard for bronchoscopists. Here you see the complex structure of the interior of the nose. This provides a large surface area for humidification, filtering, and warming of the inspired air. At the back of the nose, it's wide open. We turn to the left. There's the orifice of the eustachian tube. That leads to the middle ear. We have one on the other side as well that goes to the right middle ear. At the top of the picture is the soft palate. Now we come down to the larynx. At the top is the tongue base. You see a tonsil on either side. This C-shaped structure is the epiglottis. It's a little trap door that folds down over the larynx when we swallow. And here are the vocal cords, shaped like an inverted V, and two cartilages called the arytenoid cartilages that help to move the vocal cords. At the very bottom of the picture is the opening to the esophagus, which is normally closed. As we pass between the vocal cords and into the lung, we are now into the trachea. It is normally round, and it is supported by rings of cartilage that circle almost all of the circumference of the trachea. At the bottom of the trachea, we split off to the left lung and to the right lung. We're going to briefly tour the right lung. Here is the right upper lobe, and as you can see, the further out we go, the more branches there are, and the smaller they get. These are wide open. They're free of any signs of inflammation or secretions. This is a very healthy, normal-looking lung. Now let's talk about airway obstruction. We all have some form of airway obstruction from time to time. When we get a cold, our nose gets blocked due to mucus or swelling. Anything that physically obstructs the airway can be made worse by increased secretions or swelling, as with infection. So if a child has very large adenoids in the back of the nose, for example, he will have more airway obstruction when he has a cold and he has more secretions and perhaps some swelling. When we breathe, we pull air into our lungs by expanding our chest, thus creating a vacuum and pulling air into the lungs through the airways. When we exhale, we compress our chest and thus push the air back out again. If the upper airway is obstructed, one must work harder to get air into the lungs. In general, Obstruction above the top of the chest occurs mostly during inspiration. A good example of this is snoring. In general, obstruction within the chest occurs mostly during exhalation, and a good example of this is wheezing. Airway obstruction can be either fixed or rigid, or it can be dynamic or floppy. Now, patients with mucopolysaccharide disorders, particularly MPS II and to some extent the others, have a strong tendency to develop airway problems. What are those problems? They can involve the upper airway, the lower airway, or often both. So what are the symptoms of upper airway obstruction? First is noisy breathing, snoring, stridor. Shortness of breath with exercise may be prominent. Another important manifestation of upper airway obstruction is obstructive sleep apnea. This means that the airway may be fine while awake, but becomes obstructed during sleep. And this is characterized by irregular snoring with pauses and gasping. It may sound something like this. This results in frequent awakening or arousal, very poor sleep quality, perhaps low oxygen saturation, carbon dioxide retention. And these factors can lead to excessive daytime sleepiness, poor school performance, behavioral problems, high blood pressure, pulmonary hypertension, even congestive heart failure, and brain dysfunction. Some years ago, I had an uncle who went insane, became unemployed, lost his business, went bankrupt. And after about 2 years, he was in his doctor's office one day and fell asleep in the middle of a sentence. And you know that biblical phrase, the scales fell from their eyes? Well, the doctor looked at him and says, "Oh my God, I now understand what's wrong with you." He sent him to a sleep lab that very night. He had a sleep study. Within half an hour, they woke him up and said, "Put this CPAP mask on." And the next thing he knew, it was the next morning, and he had the first good night's sleep in many years. Within a year, on CPAP every night, he was not only no longer insane, he was back in business doing better than ever before, all because of undiagnosed and untreated obstructive sleep apnea. Lower airway obstruction. These may produce shortness of breath with exercise, wheezing, and severe obstruction can lead to respiratory failure. The typical airway obstruction in mucopolysaccharidoses can include very large adenoids, laryngomalacia, that is a floppy larynx, glossoptosis, I'm throwing $17 words at you here. Glossoptosis means a big floppy tongue base, lingual tonsils or regular tonsils. Lingual tonsils are simply adenoidal tissue at the base of the tongue. Many patients have all of these. Here is a child with laryngomalacia, a floppy larynx. You see the cartilages above the vocal cords collapse over the vocal cords, obstructing the airway every time the child breathes in. Now here is a child with Hunter's syndrome, and you see the cartilages are very deformed and floppy, and with every breath they collapse in over the vocal cords. You can't even see the vocal cords here underneath the epiglottis. I can almost make the diagnosis of Hunter's syndrome by looking at this video. It's very characteristic. Other forms of mucopolysaccharidoses, type 1 and 4 in particular, may also look very much like this. Here is a patient with very large lingual tonsils. You can just barely see the tip of the epiglottis, and these large, bulky structures here, also on the back of the throat, but mostly around the base of the tongue, are lingual tonsils, and they can provide quite a bit of upper airway obstruction. Now here's a patient. I'm going through the nose, and huge adenoids, almost completely obstructing the back of the nose. This alone would be sufficient to cause obstructive sleep apnea. We pass beyond that point to look at the larynx, and oh my, where is the larynx? We can only see the very tip of the epiglottis and a tiny little black spot that represents the airway. This is glossoptosis, a big collapsing tongue base. So this patient has 2 lesions that can produce obstructive sleep apnea. Now we're going to have an assistant grab the patient's jaw and pull upwards to pull the tongue base forward and expose the larynx. And here you can see the arytenoid cartilages also collapse on inspiration. There. So this patient has 3 separate anatomic lesions, all contributing to, and each one in its own self, sufficient to cause obstructive sleep apnea. In patients with mucopolysaccharidoses, and again particularly type 2, there may also be deposition of mucopolysaccharides in the airway lining. This can lead to severe respiratory failure. Can be diffuse or it can be localized. Here's an example of a big globular lesion in the bottom end of the trachea. This may be hard for you who are not used to looking at videos of airways, but as we pass the scope a little further down, you can now see this is the bronchus to the left lung and this is the bronchus to the right lung. And we back up and you see that this has blocked off most of the trachea. I was able to successfully treat this very cautiously with a laser. Some patients with mucopolysaccharidoses develop other forms of airway problems, and this is particularly a problem in older patients with Hunter's, MPS II. In this case, they develop a very characteristic deformity of the trachea. I call it Hunter's tracheopathy. It results from a failure of the cartilage rings that support the trachea, and also the back wall of the trachea becomes very stiff. This can produce very serious airway obstruction. It is often misdiagnosed as tracheomalacia, or a floppy trachea, which is a much more benign problem and is managed very differently. Here's an example. This patient's larynx does not look too bad. You see the vocal cords. They're moving normally. The space immediately below the vocal cords is wide open. But as soon as we enter the trachea, instead of looking round and wide open, the cartilage rings are deformed. The back wall is very broad. It's stiff. It does not open very much when the patient inspires. And as we pass down the trachea, there's not much of an airway here, particularly along here. And finally, we get down to where the right and left main bronchi take off. They are also somewhat collapsed. This particular patient had severe shortness of breath with exercise, a persistent wheeze that did not respond to asthma treatment, surprise, surprise, and during sleep had very low levels of oxygen. Shouldn't be hard to figure out why he would do very poorly with anesthesia or with a viral pneumonia such as influenza. I do not typically see tracheal deformities in MPS I, although some may have it. They are certainly not immune. I've seen several patients with MPS IV who have tracheal collapse, which looks very different from that seen in Hunter's, but was equally severe. Now here's an example of very severe tracheal deformity in MPS IV. He also has multi-level upper airway obstruction. Here's the back of his nose. We should be seeing this wide open airway. Instead, we don't see an airway. And we gently push through here. I will say that this bronchoscopy was very challenging even for myself. I've done probably 40,000 bronchoscopies in my career. Someone with much less experience would be expecting to see this and might have a great deal of difficulty getting through here and recognizing exactly what was going on. Here we've now reached the larynx. Believe it or not, those are the arytenoid cartilages that are collapsing as the patient breathes in. We should be seeing this. We're not. And we're going to very carefully pass through here. In order to make the turns, we had to turn upside down for a moment. And now we're just below the vocal cords. We're going to straighten back up again. And here you see the trachea is deformed in a different way. It's collapsed side to side to form a very narrow slit. We should be seeing this, a round, uniform, wide open trachea. Instead, we're seeing this. This is called a saber sheath trachea. And it goes pretty much all the way down to the bottom. Finally, here is where the right and left main bronchi take off from each other. So what are the treatment options for patients with mucopolysaccharidoses who have airway problems? First of all, let me say that statistics do not apply to individuals. Secondly, enzyme replacement therapy may be beneficial if begun early, but the effects on the airway are, in my experience, not very impressive. Bone marrow transplant seems to be beneficial in preventing the development or progression, but it must be done very early in life and is not a magic bullet. There are surgical options for upper airway obstruction, adenoidectomy, which may need to be repeated more than once. Supraglottoplasty is another $17 word that means trimming some of the excess tissue from around the larynx. Tonsillectomy and lingual tonsillectomy. All of these may be very difficult because many patients with MPS II particularly, but others as well, develop limitations of movement of the jaw and the neck. And access to the back of the throat and the back of the nose may be very challenging, particularly with conventional surgical instruments. What are the non-surgical options for upper airway obstruction in someone with obstructive sleep apnea? Basically, we're talking about the application of continuous positive airway pressure, or CPAP, or bilevel pressure, BiPAP, which certainly can help and may be essential. This is typically done with a face mask that fits over the nose and perhaps over the mouth as well. Supplemental oxygen during sleep may also be beneficial. Now let's talk about surgical options for lower airway obstruction. There aren't very many. Tracheostomy. Tracheostomy bypasses severe upper airway obstruction, but in many patients that I've dealt with with MPS who needed a tracheostomy, they also had very significant lower airway problems. And therefore, many of them required a customized tracheostomy tube that extends the entire length of the trachea. And this can be challenging technically. A stent is a round open device that can be placed in an airway to prop it open. While this is intuitively very attractive, we try very hard to avoid using stents because they can create a host of problems themselves. And if you cannot access the larynx and the trachea through the mouth with a rigid instrument, a stent can be very difficult to place. In some patients, we've needed both a trach and a stent. Are there non-surgical options for lower airway obstruction? Yes, supplemental oxygen, BiPAP, may be necessary, may be beneficial. Bronchodilators and inhaled steroids may or may not give some benefit, but the effects are usually very, very small. This is not asthma. The patients may be wheezing as they exhale, but their wheezing typically will not respond the way an asthmatic wheeze would respond to bronchodilators and or inhaled steroids. It's very important for patients with airway problems to maintain a very good immune status. Flu shots, absolutely mandatory. And to avoid irritants. Smoking and vaping are absolutely forbidden. Period. End of discussion. How do we diagnose airway problems in patients with mucopolysaccharidoses? One, we take a careful history. Physical examination may be helpful. X-rays certainly can also be helpful, particularly CT scans. But the most definitive way is bronchoscopy. You've already seen some bronchoscopic videos. This is how we make the most definitive assessment from top to bottom. The absence of symptoms does not prove the absence of problems. After more than 45 years in this business, I am still shocked from time to time by the severity of airway obstruction that I find when I do a bronchoscopy in comparison to the symptoms that the patient has reported. We often find the initials WNL written in a patient's medical record. These initials are thought by their author to stand for within normal limits. All too often, however, I find that WNL really means simply, we never looked. I take a biblical approach to the diagnosis of airway problems. Matthew 7:7, seek and you shall find. If you don't look, you cannot find it. Now, patients with mucopolysaccharidoses have special problems when they require anesthesia for whatever reason. During anesthesia, we lose muscle tone, and particularly with deep anesthesia, as for surgery, this means the anesthesiologist has to breathe for the patient. This means he has to supply an airway, a breathing tube, to deliver oxygen to the patient's lungs when they can't breathe for themselves because of the anesthesia. The problems encountered in the airways of patients with mucopolysaccharidoses can make intubation the provision of an artificial airway for anesthesia a really big deal. I've seen many patients who underwent a seemingly simple operation and could not be extubated because of swelling in the airway. And in many of these patients, the upper airways were marginal preoperatively, but perhaps not recognized as such. Now, here's a disclaimer. My opinions and what I am sharing with you today is based on my experience. I think I have probably bronchoscoped more patients with Mucopolysaccharidoses than anybody else on the planet, but my experience is limited to those patients that I've seen, and I am more likely to see patients who have problems than to see patients who are not having problems. If they're breathing just fine, why would they be referred to me? I don't know how often patients with mucopolysaccharide disorders go through surgeries without having any airway problems at all. But I've seen too many disasters to be complacent. In a patient with mucopolysaccharidoses, they often have limited mobility of the jaw, limited mobility of the neck, and a lot of excess tissue around and above the larynx. And this can make them very difficult to get an artificial airway into. And if they get intubated, there can still be complications. Swelling after the tube is removed, bleeding, etc., etc. Forewarned, however, is forearmed. Unless it is clearly known that the airway is reasonably normal, it is my strong recommendation that patients with mucopolysaccharidoses be intubated with the use of a flexible bronchoscope. This gives a full diagnostic evaluation of the airway at the same time and can be done even if the neck or jaw can't be moved. Furthermore, patients known to be difficult to intubate should carry a medical alert bracelet or necklace on their person at all times with appropriate contact information, etc., so that personnel involved in their management will understand what the problems are and what the potential solutions may be. When you intubate a patient, on the left, you see this is a rigid bronchoscope. This is very much the same thing we would use to intubate a patient. You extend the neck back, you pull the jaw forward, open the mouth wide, and you pass the instrument straight through the mouth between the vocal cords and into the trachea. But if you can't move the jaw, if you can't extend the neck, what can you do? Very difficult. However, a flexible bronchoscope goes through the nose, around the corner, turns again, goes between the vocal cords and into the lung. And what we do is to place an appropriate sized endotracheal tube over the flexible scope, pass the scope all the way to the bottom of the trachea, and then simply slide the endotracheal tube over the scope and into the trachea. This typically takes me 30 to 60 seconds, and in the process, I get a very good diagnostic evaluation of the airway. This is not a task for amateurs, nor for the faint of heart. I strongly recommend that MPS patients who undergo anesthesia requiring intubation do so only at major centers with experience and expertise in the management of the types of problems likely to be seen. Obviously, if there are life-threatening emergencies, you may have to deal with what you have to deal with. But particularly if the problems are known ahead of time, this is where your medical alert system can be very helpful. People need to know what they're walking into. They need to know to call for help, who to call, how to get that help. So in summary, patients with MPS, and particularly MPS II, but also other forms of mucopolysaccharidoses, often develop upper airway obstruction at multiple levels and lower airway obstruction. These issues demand careful evaluation by physicians experienced in dealing with MPS patients. In my not very humble opinion, patients with mucopolysaccharidoses who undergo anesthesia should be evaluated by a physician skilled and experienced with MPS airway issues and should have their entire airways examined routinely whenever they undergo anesthesia or when they develop persistent symptoms.
Thank you, Dr. Wood. Really, really appreciate your outstanding presentation from personal experience. I saw that for the first time. I got that information 9 years ago, and it has benefited me personally and my family. And those last few slides, I just want to reiterate how critical all of our patients, when you're looking at anesthesia, it's a very, very important thing. And I believe Dr. White even mentioned that in his presentation as well, how very, very important that is. So thank you for that. We do have some time for some Q&A, and there are several questions within the Q&A section. And I'm actually going to start, if we will, to give Dr. Wood a few minutes to look at the questions, but also start with Dr. White, if he could go through. Dr. White, there are several questions and throughout the chat related to your presentation, so I'd like to just turn it over to you, and if you can kind of walk through some of those items, that would be great. Thank you.
Yeah, sure. Yeah, thanks, Lisa. So, I mean, there's about 10 questions here, and they're kind of all a little bit different, so I can't really lump them together too much. But there's a couple questions about spinal stenosis and spinal decompression. And I think when you're talking about, there's a question about having spinal stenosis and what are the options to surgery. And again, I think if you're talking about cervical stenosis, there are not a whole lot of options other than living with the problem, because it's a mechanical issue, and so it comes down to symptoms and expectations of progressive disease. So if things seem stable and your symptoms aren't so significant, then there's no reason to do surgery for stenosis. Now, if you have instability, that's a little bit different, because if you have an unstable spine, then it just takes one bad fall to have a significant issue. So again, it comes down to symptoms, and I think that's really a discussion you have to have on an individual basis with your physician. So that was another question about the surgical side of it, about having spongy bones. Now, in my experience, and actually I just had this conversation with Mill McKenzie yesterday, and both of us have not had that experience. We've found the bone quality to be quite good in MPS. Now, they tend to be smaller bones. And I think in younger children, sometimes the bone seems to be a little more cartilaginous. But I've not encountered this. And as far as healing goes, in any bony surgery, whether that's spine, hips, or anywhere else in the body where you're cutting bones, the bones heal just fine. So fusions work well in MPS, and the spongy bone that has been described by this question is probably not really a concern. You want me to keep going, Lisa, or do you want me to give Dr. Wood a chance?
Why don't we just keep going with your questions? It looks like we've got about 20 minutes, so we've got, I think, enough time to address these and give Dr. Wood plenty of time for his questions as well.
Great. Okay. So we have a couple questions regarding surgical treatment for hip dysplasia, about whether you do the femur, whether you do the pelvis, and whether you do both hips at the same time. And then there's also questions about should you do a reconstructive procedure, meaning osteotomies versus a joint replacement? And then there's one more question about opinions about cemented versus uncemented hip replacement. So let me just talk a little bit about hip surgery in general. So hip surgery in general, I think again, the bones seem to heal just fine. In younger children, we tend to do reconstructive procedures, meaning osteotomies. In older patients, we tend to do hip replacements. So you're talking about a different patient group when you're talking about reconstruction versus replacement. So for me personally, I pretty much always will do a pelvic and a femoral osteotomy, and I personally do both sides at the same time. I think in my hands, I can do that safely. I can generally do that surgery in under 5 hours, and then I usually put the patients into a brace. I know that there are concerns. I've heard other surgeons say that they won't do both hips at the same time, and I think that's just a personal comfort level for them. I would rather, assuming that there's no neuromonitoring issues, get through all the surgeries at once and reduce the number of exposures to anesthesia. With regard to hip replacements, again, this is going to be your late adolescent patients or your adult patients. I think cemented versus uncemented. The bottom line is there's a good chance if you have MPS that you are going to need a custom type implant. Now, most implants these days are uncemented. They are press fit implants, but there may be circumstances in which the surgeon thinks cement might be better. And again, that is a very individualized question, and I think you have to put your faith in your joint replacement surgeon. But with that said, I would make sure I go to a joint replacement surgeon who has significant experience with complex hip replacements. But again, I think it's most hip replacements or joint replacements when we're talking about hips are uncemented. Now, when we talk about knee replacements, that's a different issue. Almost all knee replacements are cemented. So I think that addresses the hip issues. I had a question about carpal tunnel syndrome in Sanfilippo. Yes, we have seen carpal tunnel syndrome in Sanfilippo, and as we know, a lot of the Sanfilippo kids can't tell us about it, and they can become quite symptomatic. And most of the time they can't tell us about it, whether they're in pain or whether they're having other kinds of symptoms. So we do screen our Sanfilippo children for carpal tunnel syndrome, and I can tell you we have decompressed a fair number of children with Sanfilippo syndrome. And maybe I wasn't clear about this, but we recommend decompression at the first sign of any neurologic injury or deficit. So, and you may not see that clinically. It may only be picked up on the nerve conduction studies. Let's see, I think a question about neuromonitoring was only necessary in cases greater than 1 hour in duration. And yes, I agree. And the reason for that is because you're not going to get a spinal cord injury in under an hour. And the time it takes to set up neuromonitoring for cases that are less than an hour, it's not worth it because you can be done with the surgery before you even get the neuromonitoring set up. So we generally recommend neuromonitoring for any case longer than an hour, whether that's spine or lower extremities. I think that addresses all my questions.
Great. Thank you, Dr. White. Dr. Wood, I think there's several questions here as well regarding airway issues. So I'll turn it over to you and let me know if you can see those and are ready to go.
Okay, let me see if I can find the first question here.
I believe we're at number 12. Do typical post-transplant MPS I airway issues? Yes, sir.
Very topical question here regarding COVID-19. As any of us who paid any attention at all are aware, this is a very new and strange virus that is affecting people in ways that are unique. First of all, a significant number of patients have no symptoms at all. yet they can transmit it to other people. Some people have severe disease. One of the things that I find most interesting is that the recent research indicates that the severity of the disease that you get, everything else being equal, relates to the dose of you. And people who consistently wear a mask, even if it's not an N95 mask, have statistically a much higher probability of having mild disease than having severe disease. So wear a mask whenever you're around other people, other than within your immediate family. Any airway problem can cause issues when you get a viral respiratory infection, whether it's COVID, influenza, adenovirus, rhinovirus, what have you. I will go back also to my slide that said statistics individuals. If I could predict with great accuracy what would happen in the future, I'd be a Wall Street gazillionaire, not a simple pediatric pulmonary doc. So yeah, no matter what you do, it's possible to get severe disease. It's also possible that you get infection with COVID and you have no symptoms whatsoever. I don't see anything other than wearing masks that we can realistically do to reduce our risk, obviously social distancing, et cetera, but exposure. On the other hand, there is nothing intrinsic about mucopolysaccharidoses, whether it's type 1s in this question or others, that in and of itself make you more vulnerable to COVID disease. So I would say wear masks, do social distancing, use common sense. Seems to be drastically lacking in some people these days. I see people in big crowds wearing no masks, and some of those people have subsequently died. Do not go thou and do likewise, please. Be sensible, wear a mask, do social distancing, use common sense.
Thank you, Dr. Wood. I think the next question, I know in your presentation you mentioned medical alert might be useful, and someone asked what a medical alert bracelet might say so that you might have the proper anesthesia methods if in an emergency.
Well, again, it depends on what the actual issue is. I've seen a number of kids with MPS who have a perfectly normal airway, absolutely no problem with intubation, including a girl who's now, I think, 18 with MPS I who underwent bone marrow transplantation in the first 6 months of life. And as far as I can tell, her airway is just as normal as mine. But for those who have issues, if it's a known difficult intubation, medical alert bracelet needs to say difficult intubation, MPS, call this number, namely the pulmonologist or otolaryngologist or anesthesiologist that has been seeing that patient, who knows that patient's airway and can help guide people. Again, if you're having elective surgery, get yourself to a place where there's known expertise, preferably where they know your patient. If I had a child who I know has very difficult intubation by conventional techniques, I would have on the medical alert ring fiber optic intubation only. Okay, I think there's another question down here.
Yes, it asks if our pediatric patients should see ENT or a pulmonologist at regular intervals, even if maybe it's not known that they're having breathing problems, just to monitor the airway.
Yes, but not just any otolaryngologist and not just any pulmonologist. You need to have someone who has expertise in this area. Ask them what their experience is.
Great, thank you.
Another question here is, I have a child with MPS III who no longer eats and is having a lot of trouble with excessive saliva. They've tried Kyphosi, but are not seeing great results. What are the options? There are two major options. One is Botox injection into the major salivary glands. This is often very helpful. There are several problems with it, however. First of all, it generally requires anesthesia. It's not a comfortable procedure to undergo. Secondly, it does not last more than 2 to 4 months in most patients. It's transient. And therefore, I use it primarily as a proof of concept. Before I will consider doing surgical salivary gland ablation, I will want to see the effects of Botox. Now, the third problem with Botox is that the technique is also variable. It depends on who's doing the injection, how skilled and experienced they are. It may depend on luck, if they got the needle in just the right place or not. Our people generally do it under fluoroscopy. It also depends on the potency of the particular vial of Botox that you get. They are not uniform. But if I have a child who has a issue, I'm not expecting him to get better on his own, and he's really struggling with hypersalivation, sialuria we call it, he's going to need something. And so I will go for Botox. And if I get a beautiful result, everybody's happy, then I'll say, okay, this suggests that we should proceed with surgical salivary ablation. What we do is we tie off the ducts to the parotid glands. These are the two ducts here, glands here that swell up with mumps. Ducts enter into the inside of your cheek. You simply go in and tie off those ducts. The other major salivary glands are located under the jaw. Typically, we remove those entirely. Sometimes the surgeon will say glands, and we'll see how that works. But I don't go to surgical procedures until I've satisfied myself that the result I get with Botox is satisfactory. Now, there's one further problem with all of this, and that is that in addition to the parotid glands and the submaxillary glands, we also have about 10,000 minor salivary glands that line the entire. I have had several patients over the years, not with MPS, but with other problems, who had surgical ablation of all four of their major glands. Those patients, I don't have a method that can be extremely challenging, because there's no way other than with drugs to eliminate all the minor. And if they're hyperactive, there's very little that we can do, unfortunately.
Thank you, Dr. Wood. I know we've had a few more questions come in here for Dr. White. I'm going to pop it over to Dr. White for a minute if we can take a look at some of those.
Yeah, sorry, I missed question 7, so I'll start there. It's a question about genu valgum and when to intervene, when's the best time to intervene, and what mechanisms. And I kind of alluded to this, and maybe I wasn't real clear about it, but so for growth modulation to work, the child has to be growing. And this question has to do with a child who's not really growing and is too small for plates. And so in that scenario, if the patient can't be treated with guided growth, either because of size or because of failure to grow, then osteotomies are the option. And that can be done at any age, any time. Younger tends to do better with surgery than older patients. So I don't think there's a lot of reason to wait if this is indeed the scenario. So, and then let's see, there was a question about more questions about soft or spongy bones. And so the question is, are soft bones the same as spongy bones? My daughter's 14, still being told she has soft bones. Well, I'm not sure exactly what those care providers are referring to. Usually when we talk about soft bones, we talk about fragile bones. There are, so MPS patients, specifically Sanfilippo patients who no longer walk. So this would be any patient who really is not walking. Our bones depend on walking to maintain bone strength. And so in scenarios where children are in wheelchairs or otherwise strollers or whatever, then their bones can become soft and more likely to break. And that's a bit of a different concept than I think what these surgeons were referring to in terms of spongy bones. Because bone quality tends to be reasonably good in MPS patients unless they develop what we call disuse osteoporosis. And then the question was, is it too late for carpal tunnel syndrome at 23 years of age for severe MPS II? So that's a bit of a tough question because it's never too late for carpal tunnel surgery with regard to ability to do the surgery. The question is, what are the benefits of the surgery, and how severe is their carpal tunnel syndrome? And what is, in a severe MPS II patient who's 23, that often is, not to be blunt here, age 23 is probably an age that's long beyond the expected life expectancy for a severe MPS II. So neuronopathic MPS II, they tend to not make it past their late teens, early 20s. So it comes down to a quality of life decision of whether, this surgery is going to make your son's life better or not. So that discussion you'd have to have with your surgeon and have a personal sort of decision making about, how much is this carpal tunnel syndrome affecting his quality of life versus what are the risks of surgery. I think those are the new questions. So, it says, do small surgeries like taking ear tubes require neuromonitoring? No, because generally that can be done in just in under 10 minutes. So that's not. Lisa, do you see any other questions?
I don't see for you, Dr. White. I do see for Dr. Wood. Yes, please.
Okay. Yeah, there's a question here that says, when a child has dual disease like MPS, pulmonary hypertension, where do we find a doctor that's familiar with both, or do we create partnerships between doctors? You need multiple specialists. I'm not an expert in pulmonary hypertension. I would not pretend to be. I can be suspicious of it. I can point to the diagnosis. But the instant I suspect pulmonary hypertension, I'm going to send that patient to someone who knows a whole lot more about it than I do. I hope the cardiologist would feel the same way about pulmonary issues. Again, I get back to the ABCs, airway, breathing, and then everything else. The cardiologists like to say at least airway, breathing, and circulation, but I would say C contains things like the heart and the circulation and the brain and everything else. But it's like to have a team. It takes a village to adequately care for someone with complex disease. And that's most people with MPS who have any significant problems at all. I think every patient, regardless of their underlying disease or condition, needs a primary physician. I'm not going to deal with a sprained ankle or a urinary tract infection your primary pediatrician or general practitioner or internist can take care of that. But you all need a multidisciplinary program. MPS is not something to mess with in a community hospital. And find a place, UNC, there are many other major medical centers where there's a host of specialists who talk to each other. That is crucial. Communication is the name of the game. If I find out that one of my patients with MPS has gone to the operating room without my being aware of it, it's hell to pay with the people that arrange that. I give them what for. In the last 20 years, this happened only once. But I'm legendary around Cincinnati Children's for that. I need to know because we need to be there and make sure things go well. So I work with ENT, I work with anesthesia, I work with cardiology, I work with genetics, orthopedics, neurology, neurosurgery. We're all part of the team, and you need to have all the expertise you need coming to bear concurrently to manage the patient's problems effectively and safely.
Dr. Wood, I think that is an excellent sermon. Well, that's an excellent sermon and a wonderful way to wrap up the session, because I could not agree more. Wow. I mean, and that's why we have these conferences today, is to really educate people about those very, very important facts that you just laid out. So thank you so much. Thank you, Dr. Wood. Thank you, Dr. White, for your dedication to the MPS community. We are so grateful for all the time and effort that you put into to all of our patients and to volunteering your time for us today. So thank you. And if anyone has any follow-up questions, feel free to reach out. We'll try and get those answered. And that concludes our session today. Thank you. We'll all move on to the next. Thank you.
Thank you.